By the way, I think we should proceed to the next lecture by Dr. Teh Hong Liang. She's a consultant geriatrician, currently working in Sunway Medical Center. She's part of our development group for this CBG Management and Dementia third editions. And she's one of the committee members setting up this CBG. So without further delay, I would like to invite Dr. Teh to give the next lecture on the assessment as well as the diagnosis of dementia.
Hello, good afternoon, everyone. So we move to the next part of our CPG. I will talk about the assessment and diagnosis of dementia. So the learning objective for this lecture is, number one, we want to learn about the evaluation of cognitive and non-cognitive assessment for dementia. And they want to learn about dementia mimicking conditions. So there are many diseases might presented like dementia symptoms, but they are actually not dementia. And to learn about the rating scales for cognitive and non-cognitive assessment. Okay, so for the evaluation of dementia, so far, until now, there's insufficient evidence or data to recommend routine cognitive screening for asymptomatic cognitive dwelling elderly. So the keyword here is routine cognitive screening and asymptomatic community dwelling elderly. So means that there's no point you do a massive run of cognitive screen in the community dwelling elderly, which is asymptomatic healthy one. Yeah, it won't help you to pick up further. But you should do an evaluation or assessment of cognitive functions in those patients who presented with memory complaints, either by the patient themselves, from the family or their caregivers, or you have clinical suspicions of the cognitive impairment. You yourself as a doctor, when you see the patient, you have suspicions. For example, the patient comes to you, they tell you the symptoms, you tell them your plan and diagnosis and what to do, what medicine. After that, they ask you repeat again. They ask you again. They ask you the same question 2-3 times in your clinics, then you should have suspicion already. Or the patient coming with poor control diabetic or poor control hypertension. Maybe they are non-compliant because of the cognitive issue. They forget to take their medicines. So these are clinical suspicions by the clinician judgment. Then you should assess them for dementia. Okay. Or those patients at risk. Those just now, Dr. Vala, she presented those risk factors. So those patients have high risk factors. Then you should do cognitive assessment. Okay, you should ask them whether they have cognitive problems or not. And for elderly with questionable mental capacity. To make it simple, we come out in the CPG with this 10 warning sign. This 10 warning sign is recommended by Alzheimer's Disease International. So this one is easier for the public to understand, also for the GPs to understand what are the warning signs of dementia. So these are the 10 ones. You can print it out and put it in your clinic or distribute to your patients. If they got either one of it, then they should come forward for further assessment whether they got dementia or not. These are the warning signs. So number one is memory loss. Usually memory loss is more of recent memory loss. Recent memory will be affected first, and then their remote memory, long-term memory will be still preserved at the early stage. Number two, they have difficulty performing familiar tasks. Means those tasks that usually they can perform one now become difficult. For example, a makcik who is good in cooking one, now the cooking got problem. The taste is changed because maybe she forget whether she put salt or not, and then she put again at the beginning again. So the taste of the cooking it changed already. Number three is problems with language. Language can be language in speaking, writing, or reading comprehensions. Yeah. So sometimes they have word finding difficulties, or sometimes the family will tell you the patients looks like don't understand what they say. Yeah. So problem with language. Number four is disorientation to time and place. So a lot of time you can see in the newspaper, those elderly get lost, cannot find their home, then they put out in the newspaper. Yeah, these are disorientations or disorientation about the time. So for example, for Muslims, sometimes they confuse about the time for their prayers. Also, these are the signs. Number five is poor or decreased judgment. So the judgment become poor. For example, one of my patients, after she came back from market, she bought all her grocery. She don't know which one put in the freezer, which one she put downstairs. She put all the veggie and the fruits into the freezer. Yeah, so this is poor judgment. So sometimes they also easy conned by those people, and then they lost their money. Yeah, so poor decreased judgment. Number 6 is problem keeping tracks of things. So for us, for example, now you're attending a CME now, you need to keep track on the topics and what we say. So when you engage in a conversation, you need to keep tracking what is the conversation so that you can join the conversation. So dementia patients, they have problem in keep tracking on all these things. So number 7 is misplaced belongings, misplaced things. Usually they misplace their wallet, their specs, their keys, they cannot find it. Usually for us, we also sometimes we misplace things, right? Yeah. For example, we also misplace our phones, but we have the intact tracing back, like keeping tracks of things. You can think that, just now where you went. You went to toilet. So you go back to the toilet, then you can find your belongings. But dementia patients, they lost this ability. They cannot find back. They cannot trace back. Yeah. So they always misplace belonging. Then this one will lead to sometimes they will start to accusing people stealing their things, stealing their money because they cannot find it. So they lead to changes in mood and behavior. So sometimes changes in mood and behavior also a warning sign of dementia also. They become very moody, very easily sensitive, irritable, or they become very quiet. Previously very friendly and cheerful one, now become very quiet. So change of mood or behavior also a warning signs. And then number 9 is trouble with images and spatial relationship. So this one is a visual spatial functions. So for example, driving is a skill that require visual spatial functions. So sometimes the patients might present with a complaint of they easily get into the accidents. The family may tell you this one, yeah, scratch the cars, but they cannot remember where they scratch the cars. Yeah. And then number 10 is withdrawal from work and social activity. They become withdrawal, isolated. They don't want to join people because sometimes they feel inferior. People may laugh at them because they keep on repeating themselves. Yeah. For example, they go out coffee shop, drink coffee, chit chat with their friend. They keep on repeating the same topic. The friend laugh at them. Then they feel embarrassed. That slowly, they withdraw from their social cycle already. Okay. So these are the 10 warning signs. So you can put it in your clinic so that when the patients or the family, they read this, then they'll bring forward for your attentions. So if let's say the patient is suspicious or they got warning sign of dementia, then you should proceed with clinical assessment. So if you notice from CPG dementia, a second edition to a third edition, we change the words. From cognitive screening, we change the word to cognitive assessment tools. So we don't encourage screening. This is an assessment. When you suspect the patients have dementia signs and symptoms, then you straight away proceed to assessment. So the assessment can be divided into clinical assessment, your lab tests, and your brain imaging. So we start with clinical assessment first. Clinical assessment, as we all train as doctor, we usually start from history. History can get you 80% of the diagnosis already. Okay. Then physical examination, cognitive assessment, and non-cognitive assessment. So history onset is very important. So usually dementia is gradual onset and progressively deteriorating over months to years. So it is a chronic conditions. If you get a history of acute deteriorations, acute change of cognitive functions within weeks or days to weeks, acute one, it is always delirium until proven otherwise. So dementia is a chronic one, months to years, and slowly progressive. Sometimes they can tell you exactly when it started 2 years ago after the surgeries or afterward, or they cannot tell you. This is very insidious onset. So this one, insidious one usually is Alzheimer. The acute one, they can exactly pinpoint when one usually is vascular. Yeah. And then the cognitive symptoms, you can ask whether they have recent memory loss or not, and then whether they disorientated time, place, and then whether they have language problem, word finding difficulties, difficult to express themselves. And then you also need to assess the non-cognitive symptoms. Non-cognitive symptoms, basically you need to assess 2, because this one need to fulfill the diagnostic criteria later I'll talk about. So number 1, you need to assess their functional status about their activity or daily living, ADL. So ADL, we divided into 2. One is basic ADL. Basic ADL means self-care. Like feeding themselves, changing clothes, go to toilet, pass urine, pass motions, and then brushing teeth, self-care, all are basic ADL. Instrumental ADL means higher level of ADL, means those need instrument one. For example, cooking. is a higher level, instrumental ADL. Using handphone, self-administered medications, all these are higher level of ADL. Go for shopping, grocery shopping, all these, they use money to buy things, all these are higher level of ADL. Okay. Driving also is IADL, instrumental ADL. So you should assess what they can do previously, what they cannot do now. So this is loss of function. BPSD stands for behavioral and psychological symptoms of dementia. So you need to ask about the mood and behavior. Sometimes depression also can present it as like dementia symptoms. They become forgetful, but actually they have depressions. Okay, so now we look into a diagnostic criteria. So just now, Dr. Chan explained about whether you want to use the term major neurocognitive disorder or dementia. It depends on which diagnostic criteria you use. So ICD-10, they still remain the words dementia, but DSM-5, they changed the word dementia to neurocognitive disorder. Okay, so this is because they say want to reduce the bias or the discriminations toward dementia people. But for us, it's the same now. We understand it is the same. So major neurocognitive disorder is equivalent to dementia. There's another one is mild neurocognitive disorder equivalent to your MCI, mild cognitive impairment, which is a pre-dementia state. Okay. So let's look at this DSM-5. I use DSM-5 because it's easier to understand compared to ICD-10. Okay, so DSM-5, A criteria is evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. So there are 6 cognitive domains here. So based on the concern of individual, a knowledgeable informant, or the clinician, that there has been a significant decline in cognitive functions and a substantial impairment in cognitive performance, preferably documented by standardized neuropsychological testing or its absence, another qualified and quantified clinical assessment. Very long sentence. I make it short for you. I cannot see this one. Okay, I make it short. So means there is decline in one or more. You just need one of the 6 domains. So from complex attentions, executive functions, learning and memory, language, perceptual motor is your visual spatial. It also includes your auditory motor also. So it's a visual is usual visual spatial functions, and social cognitions means social interaction. You just need one out of the 6 to diagnose dementia. Okay, there is a decline from the previous functional level. Why they revise the criteria? Because from the SM4 to like this, because we notice some of the dementia patients, they don't present with memory complaints. They presented with language. For example, those primary progressive aphasia patients, they presented with language complaint. The memory is intact. Those frontotemporal dementia patients, they presented with social behavior issue, disinhibitions, rather than the memory or the executive function. They still can function well, but the behavior got problem, but actually they are dementia. So if you follow the previous DSM-4 criteria, you might miss all this. Yeah. So they revise it to become like this. You just need 1 out of 6. And then based on the patient self-reported or from the informant or you yourself, clinician suspicious, and then plus objective assessments documentations. So you must perform a cognitive test. And criteria number 2, it affects the activity of daily living. Okay. Criteria number 3, C, you must exclude delirium. D, you must write down with or without BPSD. For us, you just need to fulfill A, B, C enough. If D, you have no time to assess, it's okay. You refer to specialists later, we will assess. So the staging of dementias, in previous CPG, it stated that you stage according to the MMSA score, but now we know that MMSA score got some bias, educational bias, and not so reliable. So now in this CPG, we recommend you to stage according to the functional status of the patients, according to the DSM-5. So this is much more easier. So from the history itself, you can know whether the patient is mild, moderate, or severe stage. So mild stage of dementia means they have difficulty in IADL. but they still independent for their basic ADL. So self-care, no problem, but higher level, they cannot. Means cooking, they got problem, they cannot handle money already. But self-care, going to toilet, bathing, feeding themselves, still okay. Moderate means difficulty in basic activity or daily living. So moderate means the basic ADL affected already. So maybe they can feed themselves, but change clothes or bathing, they need help already. Yeah. And then severe is fully total dependence. Means walking also need help, incontinence, need 24 hours diapers, and then they need people help for feeding, changing their clothes, clean up themselves and everything. So total fully dependent is severe stage. So this is much more easier from the functional state. Okay, so history. Then physical examinations, you basically need to rule out other differential diagnoses. So number one, you look at the overall well-being. Are they dehydrated? Are they look lethargic, septic looking? This one basically want to rule out delirium. And then are they having good eye contact with you, or they are very quiet, avoid eye contact, and very miserable looking, they have low mood, then maybe you need to suspect depression already. So look for signs and symptoms of hypothyroidism, signs of anemia, maybe some B12 or folate deficiency. Check their vision, check their hearing. Sometimes patients come to me, memory issue, but actually we check is impacted earwax. After we clear the earwax, it is clear the patient don't have cognitive issues. And check for any focal neurological deficits. Sometimes can be a vascular. And Parkinsonism features. It can be due to Lewy bodies or Parkinson disease dementias. And other involuntary movement, because there are other types of encephalopathy which can present like dementia mimicking conditions. So all this because we need to rule out these dementia mimicking conditions. So this one you can find in the CPG also. We list out the common dementia mimicking conditions that we encounter. So hypothyroidism, you must rule out because this is easily treated. If you detect early, it can be potentially reversible. Vitamin B12 deficiency, folate deficiency, hypercalcemia also can present with confusions, memory loss, cognitive decline, neurosyphilis, HIV-related dementias. So now with the heart therapy, our HIV patients is living longer and longer. So actually there are one condition we call HIV-related dementias. Okay, and then conditions that can be excluded by imaging and EEG, those normal pressure hydrocephalus, subdural hemorrhage, brain tumor, CJD, autoimmune and limbic encephalitis. CJD and autoimmune limbic encephalitis, these two are the rapid deteriorating cognitive decline. Usually from independent to become dependent, it takes about months, 3 to 6 months, it rapidly deteriorate. This one you need to refer neurologists for the MRI, LP, EEG, and then we treat differently. It's another condition. It's not a dementia. Okay. So for yourself to make it easy, after you suspect, you take the history, physical examination, you do the blood test. Uber count, renal profile, liver function test, calcium level, B12, folate, thyroid function, VDR or HIV if indicated. Then you can rule out majority of the dementia mimicking condition. If you can, order a brain scan, CT brain or MRI. If you cannot, then you refer. Then the specialist will order. EEG, I think GP, don't forget about it, you refer. Okay. So now we talk about the cognitive assessment tool, which one to use? So there are many cognitive assessment tools available now. With the new digital era coming, so now we even have digital cognitive assessment tools, right? Yeah. So a systematic review on cognitive assessment tool in Asia, it shows that educational bias were present in 74% of the studies with wide range of sensitivity and specificity, which may lead to overestimation of dementia. So all the current available cognitive assessment tool, majority are developed by the developed country, overseas country. So if let's say you apply to Asia's, then there are actually majority of them shows educational bias, and there are potential cultural and language bias also. Yeah. So the cognitive assessment tool got its limitations. So the diagnosis of dementia should not be based on the cognitive assessment score solely. So the score is help you to support your diagnosis. remember the dementia, the DSM-5 criteria. One of the criteria is you must have evidence of the decline in one part of the cognitive domain. Okay, so it just helps you to support a diagnosis. You shouldn't say, oh, the MMSE less than how much this is dementia. No. You diagnose dementia based on whether it fulfills the criteria or not. Okay, so which one to use? There are so many. So the choice of the cognitive assessment tool depends on the clinical setting and the experience of the clinicians. So it depends on you. Your clinic busy or not busy? Because some of the cognitive assessment tools are very short only. 3 minutes you can finish. Some are very long. You take up to 30 minutes or 45 minutes also can. Yeah. So it depends on your clinical setting and your experience, whether you are trained to use it or not. Because some cognitive assessment tool, you need training, then only you can perform it. Some no need training. Yeah. And then some is easy to interpret, some is difficult to interpret. So it depends on your confidence and your experience. So for further evaluation for detailed neuropsychological tests can be considered if the diagnosis of dementia is still doubtful after initial assessment or to determine the subtype of the dementia. So this one means, for example, the patients come to you, they say they are forgetful. You did the evaluation already, then for example, you perform a cognitive assessment, MMS is normal score. Yeah, it's normal score. It's score like very high, 28, 29, but still very suspicious. They are not sure, especially those higher education patients. So there are ceiling of the scores, mean the MMSE is not good enough to detect the decline in the cognitive functions. You can refer for neuropsychological tests. Usually it's done by neuropsychiatrists or clinical psychologists. They also can do for a proper neuropsychological test. So this one to help us to further determine how is their function, and they can subtype the dementia for us also. Okay, so in our CPG, we list down those commonly used cognitive assessment tool for you to choose which one you think suitable for you to use in your clinic. So we divided into informant rated and also the direct patient's assessment. Informant rated means you ask the caregiver or the family members. So there are two, one is 88, one is IQ code. So IQ code is validated in Malay. 88 is not validated in Malaysia, okay? So these are the questionnaires, then you ask the family members, then you score, then you can know which component is affected. So another one, this one is more commonly used, direct patient's assessment, means you assess the patients yourself. So Mini-Cog and the AMTS, these two are the easiest to use one. Very short, and it takes about 3 minutes, not more than 5 minutes to finish. And then the sensitivity and specificity also very good. But these two, there is no local language validation studies done. Okay, but it's okay to use. So Mini-Cog is very easy. You ask we put it in our CPG also. You just ask the patients to remember 3 objects. You ask them to draw a clock. After that, after drawing a clock, they need to recall the 3 items. Then you can assess already. So AMTS is 10 questions. But these two, they only assess 2 cognitive domains. The other more complex tests for MMSE, MOCA, ACE, VCAT, SLUMS, all these, they assess more cognitive domains, 4 to 5 cognitive domains. Yeah, so usually all these more complex tests, it take a longer period of assessment and need some training for you to administer the test. So we also list down which one is validated in what language, and also those star one, for MMSE, ACE means they have copyright. Actually, you need to pay if you want to use it, but usually no one check lah. Unless you want to publish it, then they will ask you to pay. So you still can use, just to remind you, it is copyrighted. Okay, non-cognitive assessment tools. Actually, there are a lot also. So we also list down. If you have no time to do, it is okay. Just to let you know, actually, if I refer to specialist clinics, psychiatrist clinic, memory clinic, geriatric clinics, then we will do all these assessments. So for ADL, we got the DAD, we got Bistro. For mood, we got CSDD, MADRS, and also GDS. For behavior, we got the neuropsychiatric inventory and behave AD. Caregiver burden, we also need to assess the caregiver burden. So we got Jarit burden interview. Okay, I think this is almost come to the end of my lecture already. So this is the algorithm. This is the algorithm. So from the presentations of signs and symptoms suspicious of dementias, then you need to perform your history, physical examinations, then your cognitive assessment. Then if you detect something abnormal, yes, then you run the lab test like just now we recommend. So if let's say got B12, folate, all these deficiency, please treat it first. Yeah. Then if nothing abnormal, then you can refer. You can refer either to the guidelines say refer to a geriatric psychiatrist or psychiatrist, geriatrician or neurologist for assessment, depend who is available at your area. For example, all also don't have, at least a general physician should be able to help you. Okay, so for my personal recommendations, if let's say from your assessment, you find out the patients have a lot of mood issues, depressions, agitations, hallucinations, and all these delusions, then better refer a psychiatrist or geri-psychiatrist for assessment. Yeah. So if let's say the patient have a lot of medical conditions, diabetic, high blood pressures, old strokes, yeah, then maybe a geriatrician or neurologist might help you better. So those with involuntary movement, for example, Parkinsonism features, maybe geriatric and neurologists will be able to assess better. So these are for the general guidelines. So come to us, we will do further assessment and tests, then we will diagnose the subtype of dementia, see which type, because different type, the prognosis is different and the treatment approach also slightly different. Okay, so take home message. The diagnosis of dementia should be based on the detailed history and physical examination and supported by cognitive, functional, and behavioral evaluations. And diagnosis of dementia should be based on either DSM-5 or ICD-10. Okay, that's all. Maybe I should answer the question myself. Stop sharing. Yes. Q&A. Which one I should start? Is one-step dementia risk? No. No question for me. Let me see.
There is alpha. That one, alpha report actually the last one.
Answer already. Okay, so how many warning signs need to fulfill the diagnosis? No, warning sign is one only. Then you do your clinical assessment, then to see whether it fulfill the criteria or not. Oh, okay. So, okay lah, no questions lah. Tak ada, sini tak ada question lah. Okay, thank you.
So, in Minicog is an assessment scale for you to do a little bit of screening. The diagnosis is still made through your patient's clinical presentation history, taking physical examination, as well as mental state examinations, plus other investigations. All right. So it's not a diagnostic tool. Then earlier, there was some participants, they have made a query on how to differentiate between delirium and dementia. Okay. Basically, dementia is sometimes can be quite difficult to differentiate from delirium, but basically these two can be differentiated by the onset. All right. For dementia, the onset is usually gradual, while for delirium, the onset is very, very acute kind of onset. Other than that, for delirium, the attention is heavily affected. All right. But for dementia, it's only the memory plus the other cognitive functions which are affected. And delirium is always also associated with some other medical conditions like infections, etc. causing them to have acute confusional state. I'm more interested to do assessment, prevention, and dementia. What tests to do? All right. Okay, so again, you still need to go through the history taking, okay, going through the clinical presentation of the patients, then you can try to do all those assessment tools for the patients. Then you do a sets of investigations, either blood or MRI, CT scan. Then you come to the conclusions. Can we use Pakal Haji dementia screening as a tool? Yes, you could. I think they're still using ECAT. Is it ECAT, right? Still using ECAT. Okay, you can use. And quite unfortunate, this group of usually they're elderly. They plan to go for Hajj. If let's say they are diagnosed with dementia, according to the guidelines, I think they are not allowed to. So I think that's most of the questions. Dear participant, in primary care setting, investigations are expected to do prior to referral. All right. I think some of the investigations, like some of the more advanced blood tests, all right, like vitamins, I think is not available in general, what we call general practitioner setting. Then you have to refer them to a tertiary center. CT brain as well as MRI, usually you have to refer to a tertiary center with these imaging facilities. How to differentiate memory issue with early onset depression? Yes, very good. For depression, a lot of times they come out with those symptoms which can be differentiated from dementia, especially those physical symptoms like lethargy. They might complain to you with low mood, poor concentration, etc. Well, for dementia, I should say, if let's say you're trying to ask them questions, they are more energetic than those patients with depressions. All right, they will try their best to answer you, despite the answer might not be very relevant or accurate. All right, so it still depends on the clinical presentations. Again, those patients with dementia, the cognitive presentation is more compared to those patients with depressions. They are actually more on those mood presentations. How early the appointment can be given in government? Okay. Probably I'll answer you later.